Thank you again for joining Help Patients Manage Anxiety and Depression via Telehealth, presented by Anytime Pediatrics and Chattis. So I'll start off by introducing our panelists today. First, we have Dr. Colleen Kraft from Mia Bella Pediatrics in California and the Children's Hospital of Los Angeles. She's also served as the president of the AAP, and we're very excited to have her. Next, we have Dr. Barbara Periard from Forest Hills Pediatrics. She serves as president of Forest Hills Pediatric Associates and is a fellow of the AAP. We also have Dr. Mick Connors. Dr. Connors comes to us from Nashville, Tennessee. He is the CEO and co-founder of Anytime Pediatrics and a practicing pediatric ER physician. He also serves as the chairman of the board at the Institute for Pediatric Innovation. And finally, we have Dr. Barbara Howard. Dr. Howard serves as the president of Chattis, and she is also a national speaker on child behavioral problems and is a past president of the Society for Developmental and Behavioral Pediatrics. I'll let you guys know that this presentation will be recorded, so you'll all receive a recording of the presentation tomorrow, which you're welcome to view and share with others. We'll also have some time for Q&A at the end, so I'll hand it off to Dr. Connors and we'll get started. Hi, Dr. Connors.
Hi, Darby. Thanks for getting things set up, and really look forward to talking with everyone today, really about anxiety and depression, amidst the pandemic, and how we can utilize a variety of tools, including telehealth, including Chattis screening, including care managers, kind of a comprehensive approach to anxiety and mental health for our kids and teens. So obviously, COVID has been a challenge for the mental health of kids, and there's been many ripples. We've talked a lot about COVID and its challenges from a medical standpoint. I think one of the things that we're clearly seeing now is also the impact on mental health. So for kids, it's been changes in routines, break in continuity of everything. Their learning is different, their healthcare is different, their relationships are different, missing significant life events. I was just talking to Dr. Periard before we got started, and she has a high school graduation tonight, which is great. And they actually even get together afterwards, which has been a long time coming. And I think for a lot of kids, there's been a loss of security and safety, just, being at home and trying to sort through where exactly they can get care or get help, all those kind of things, and including food insecurity as well. Next slide. So there's a couple of surveys that were done that were pretty remarkable, and our panelists will share kind of their numbers as well. But from child and adolescent surveys, up to 43% of kids reporting depression, 37% anxiety, 31% reporting both. More than 50% of our kids, suggesting that they have had moderate or severe impact on their mental health, and certainly the impact on households. Feeling bored or worried. We talked about food insecurity, challenges of learning, remotely, and certainly the missing out on social activities, and I'm sure a whole lot more social media, that's going on. And I think we probably all have our opinions on whether that's good or bad. Next slide. So of course, we always think too about the inequities and disparities in care. And of course, COVID hasn't been kind to those who have lesser opportunities, lesser access. So minority youth are overrepresented. Economically disadvantaged children face nutritional challenges, lack of protection, and some of those securities. They lack the digital platforms for the underserved. And they're at greater risk for violence, increasing risk for depression, anxiety, suicidality. So, as I look at COVID and what we've learned, I think it's really brought to the forefront how much disparity is there and how significant the impact of inequity and disparity is as well. And certainly mental health is not excluded at all. So I think part of this, the goals for today are really to think about, do we wait for the kids to come to us? Are we waiting for them to come and say, I'm at an issue or I have a crisis? Certainly in the pediatric emergency department, we see the kids that are kind of at in crisis mode, are ready for a mobile crisis or need admission. So one of the great things about working in virtual care and telehealth and working with pediatricians like Dr. Kraft and Dr. Periard and Dr. Howard is really, they're truly on the front lines to intervene early, to identify things early, and I think we can learn a lot from them today as their impact, as their ways that we can impact mental health for kids before it becomes a crisis. And so they're going to share with you kind of their approach and how they come at it. So I think they are certainly great resources. So Colleen and Barb, I'll turn it over to you. And as Darby mentioned, we will have ability for Q&A at the end. You can either put it in the chat or in the Q&A, and happy to reach your questions at the end of the webinar. So Colleen, I'll turn it over to you.
Okay, well, thank you so much for the introduction there. One of the things that I tell a lot of my colleagues is that being a primary care pediatrician is kind of like playing in the outfield on a baseball team. So you have a lot of ground to cover. You're expected to catch any fly ball that's out there. If you drop it, you're toast. But you don't get the accolades that the pitcher and some of the other people on the team get. At the same time, your outfielders are where your heavy hitters come from. So there's a lot that we can do as primary care pediatricians. And within these learning objectives, let's first of all recognize the infrastructure needed for primary care practice for the management of patients with anxiety and depression. We're going to talk a lot about workflow from the pre-visit planning through the visit to follow up in practice. And I'm going to ask everybody to commit to a partnership with one community organization, resource, tool that's going to help in the care of your patients with anxiety and depression. Next slide.
So as Colleen was saying, the first step is really making sure you have a good infrastructure in place to get started. And so I highly recommend that you start with a care manager or somebody who can be your touch point, that specific person, because most of these patients come to you through a phone call. The parents are worried about their child. Maybe the child's even old enough, a older teen, that they call you. So it's nice to have a touch point that's familiar to them. They don't have to re-explain their story every time they call. So to have a care manager who specifically is available to your families for their mental health needs. It does not have to be a mental health professional. In our office, it's an RN. But she also has a connection to the behavioral health community. She knows the resources out there. She has met with them. She has gone to their offices, gotten a feel for the type of patients they like to see. And so she serves as kind of the liaison to refer patients to the greater behavioral health community in our area. And then, of course, data. I'm a data geek, but it's always going to be beneficial if you start collecting data. Maybe you don't even know where to start, but just start collecting something. It will change over time as you continue your quality improvement process in your office to improve the care that you're providing your patients. But we've started, and I'll address this later, looking at our PHQ-9s and our GAD-7 scores on our mental health patients. And then, of course, to have the technology to do this, take advantage of your EMR and your different resources to track these important data points, and to also make sure that you're giving consistent care to your patients, whether it be, in our case, the consent form to communicate with these mental health professionals. Obviously, it's more strict than just plain HIPAA when it comes to mental health. So when we're referring patients to the mental health community, we specifically request that the patient give us permission and consent to communicate back and forth. Also, to have the technology that can make sure you are getting these patients into the office in a timely basis. And then, can you track the scores? In this case, as we talk about depression and anxiety, your PHQ-9 and GAD-7 scores, can you set it up so that you can track these? You can capture moments where you might be falling behind in the frequency that you should be administering these tests to your or these surveys to your patients. And then also, can you find a way to track within your system that consent that you got to communicate with behavioral health specialists? Well, now that you have that consent, are you getting that feedback from them? And can you incorporate that into the care that you're providing? Because we know that you might be able to get them out to some specialists in the community, therapists and psychologists and the like. But ultimately, we in primary care and pediatrics are responsible. So to have the technology in place to be able to capture this information and keep yourself accountable to all of these measures.
And a little bit about the screening tools. Have them collect them prior to your appointments. We use the G87, the PHQ-9, and the suicide screen. When you're putting together your EHR templates, make it so that, first of all, you can really streamline your documentation with the visit. But secondly, you can capture the components that you're going to need to be able to code and be paid for this visit in the way that is actually going to make it doable for your practice. And then finally, have the telehealth equipment there and available that makes it easy for families to get in touch with you and for you to actually conduct the visits. Let's go on to the next slide. So we're going to talk a little bit about workflow here, because how you do these visits are really as important as actually doing them, and having a structure to this is really helpful. And I'm going to let Barb talk about pre-visit planning.
So as I alluded to when we were talking about the infrastructure, then comes the communication piece, where the primary care provider, in preparing for this visit, communicating with your care manager, did she or he help you do some pre-visit screens? Are they already back? Because they can be submitted electronically. So to review those, and if there's something worrisome, having your care manager alert you to that. The care manager is going to have a pretty good idea, if she's that touch point person within your office, that this is going to be a pretty time consuming visit. So make sure you're dedicating the appropriate amount of time to this this upcoming visit. If there's been a if it's both not just pre-visit planning for the initial visit, but subsequent visits down the line, looking back at some of those surveys that you've done, are their PHQ scores improving? Are their G87 scores improving? So looking at those sequentially, and to have a good idea of what you're walking into when you go into that room or go into that televisit with that patient. Seeking those records from the consultants. That's a really time-consuming process, making those phone calls, sending over the fax, or requesting records and some type of communication of how this patient's doing. If they're seeing a therapist or psychologist or a counselor in the community, can you get some feedback from them of how this child's doing? Because they might be seeing that person with much more frequency than they're seeing you. So to be able to pull in that information. But as we know, sometimes it's like pulling teeth. So the care manager is very helpful in pulling that in. And then again, making sure that you have consent. So taking all these pieces together as you prepare for the upcoming visit. And go ahead, next slide. Yeah.
Okay, next slide. So during the visit, some of what you're going to do is review the screening result. And some of the questions we've gotten is, how do you get families to fill these things out before they actually come into the office? You do the best you can in terms of using a portal or using that type of communication, but sometimes that doesn't happen. And sometimes what you wind up having to do, if you have families who are not going to do this beforehand, make their visit 15 minutes beforehand so they can fill these screening tools out and you can review them during the visit. Makes that a little bit harder if you're doing that via telehealth, but you could actually ask the family and ask the team during that visit, or you could have either your point person for care management or your nurse do that beforehand. You want to follow that EHR template, and because that will actually help to structure the questions you're going to ask, some of the consistency of what you're going to ask and how you document this. We talk about visits in person or telehealth. I think a lot of my colleagues who do a lot of this would like to have that first visit at least in person, to do a physical exam, to set forth some of the real importance of what needs to go on through here. And then depending on the situation, depending on the patient, we always have discussions with the patient about our next visit. Do you think we could do this by telehealth, or do you feel more comfortable coming in, or do we need to come in? We're going to talk a little bit about care planning. What are our jobs for the next steps? I mean, what is the responsibility of the patient and parent? What is the responsibility of us as pediatricians? And what are we going to check back in on next time? Billing and coding, setting up that medical decision making. We're going to talk a little bit more about that and how we structure, how we code and bill for and are paid for these visits. And then how do we do follow-up? So these are all pieces of that visit. Let's go ahead to the next slide. So some of the tips for ongoing management. That care management touch point is really important. And if you have a care management manager, that is wonderful. Some practices are small enough that they really can't afford a care manager, but there may be a staff person who is interested in the role of doing this. And that person can really be trained. It's often a person in your staff who has had either behavioral health issues themselves or with their children, and they're interested in this. And you can really groom somebody in your office to be that person who is the touch point for the kids and the families in your practice. Your list of resources, really, really important. And I'm going to give a shout out to Susie McNulty, who is our managing partner at Miabella Pediatrics, because she has an extensive list of who our therapists are, who are the psychiatrists, which ones take insurance, which is a big deal in Southern California. What insurances do they take? What are the lists of intensive outpatient programs, partial hospitalization programs, and residential programs? Because we are seeing far too many of our kids who need to be going there. And we know after the first couple of visits that they're going to need more than what we're going to be able to provide for them. And in that case, working with your care management touch point, but really, again, giving the list of these programs and getting families involved in already looking for that next level of care is important. Barb, I'm going to have you talk about registry and collaborative care models real quickly.
Yeah, so I'll talk more a little bit further into this presentation about the collaborative care model, but just having your electronic medical record track these patients to some extent. Either you can do it kind of formally, where you give them a diagnosis of depression or anxiety, and therefore enrolls them within your EMR in some type of care plan, where then you can establish criteria. Or you just, keep a HIPAA compliant spreadsheet of some sort, where you are just making sure that these patients are not falling through the cracks. The collaborative care model is kind of that one step up, like Colleen was saying. There comes a point where it just might be exceeding what you are capable of and what community resources are available to you. And so my office is literally this month partaking in a program with our physician organization to enroll patients in a collaborative care model. So I'll speak more to that in a bit.
Had a great question about patients showing up for well visits and kind of, oh, by the way, I'm having suicidal ideation. What do you do in those instances? That's a place where some of your screens really, really efficiently during that well visit might actually help to identify who needs care now and who is somebody that you can go into depth with this in a week. And even doing that within the well visit helps to organize that family and that child's mind in terms of where we go next. One of the resources that I didn't mention in there that's really important is understand and try to connect with who does crisis care, because there are organizations, often they are publicly funded, who will come to your office or they will meet a family at an emergency department. But if that child is truly suicidal at that well child visit, there are things that you can do with them that day with using some of your local crisis management. And that really is something that we've had to begin to use because we're seeing this. So good question. But we're going to go into our example patient here and how we start from the beginning to the end here. So this is our 14-year-old with no major past medical history. She's missed her friends during the pandemic, is not sleeping well. She's gained 15 pounds in the last 6 months, and now she's just embarrassed to see her friends. She used to be an A student. Her grades are now C's and D's because she just can't get into Zoom school. She used to play soccer, but now she doesn't feel like getting out of bed or being active. She did have somebody in her family who was hospitalized with COVID-19, and this actually began to cause a lot of her worries. She was worried about her parents dying from COVID. She can't get these thoughts out of her mind. She denies suicidal intent. And a couple of months ago, she started seeing a therapist. She thinks that it's helpful, but it's not enough. So this is our patient. Let's go on to the next slide. And I have Barbara talk about pre-visit planning.
So as I suggested earlier, in pre-visit planning with this patient, it's touching base with your care manager, or again, it might be a particular individual who becomes your touch point within the office, because they will hopefully have the most contact with this patient over the preceding few days to weeks before they presented, and just kind of get the lowdown of what's going on. Surveys, when our patients call and are concerned and are coming in with the concerns about depression or anxiety, our care manager sends them surveys electronically through our portal to fill out and return, and so to review those in advance. And then again, seeking those records from anyone. This patient in our example has seen a therapist. Can we get a consent form in order to speak with their therapist and learn a little bit more, see if there's other things that we should be looking at. The possibility that maybe there's some background trauma or drug and alcohol use. Do we want to be sending out other surveys to look at other information on this child, just other than our standard PHQ-9 and GAD-7s? So just touching base and kind of getting ready and knowing what, as one of the questions that Colleen was discussing, you don't always know. The patient doesn't give you as much of a warning. They may come into a well visit and say, oh, by the way, but if you do know in advance, as much preparation as possible to help go into that visit as prepared as you can.
And so again, during the visit, you want to review the results of the screens. Your template is going to focus your visit, but I start with an open-ended discussion. And sometimes what I'll do is review the results of the screens, ask what's happening. Can you give me some details? What are some of the things I need to know about why you're feeling the way you're feeling? Usually that first visit will be in person, and I'll want to do a physical exam, and it's sometimes in follow-up we'll want to do that as well too, particularly if you are looking at weight loss or weight gain, if you're looking for cutting, if you're looking for any sorts of things on physical exam that might suggest that there may be a substance abuse component to this, and that follow-up can be via telehealth. Next slide. And these are just some examples of some of the screens that come in through here. This is the GAD-7, really looking for anxiety. Next slide is this is a screenshot of parts of the PHQ-9, looking for depression, and then the ASQ suicide screen. And there are a lot of questions in the chat about suicide screens and how we should be talking to people and how we do this. So we actually do have our patients put this through the portal as well too, but there are some practices I know where there is actually a care manager or a nurse or somebody who's the point person that actually asks the questions on here, only because if you get these answers in real time, you're more likely to be able to act on them. But if you look at these and you look for that input each time, you will often see where your kids are getting better or getting worse, and you can actually look to talk about planning. You can look to talk about increasing levels of care with this. Next slide. So our initial management here. So our patient is admitting to feeling sad. She doesn't want to do the things that used to make her happy. She doesn't want to see her friends. And this is, again, despite 2 months of working with a therapist. So a question about do I refer as the ASQ as ask? I mean, you can call it either one of them. I always confuse the ASQ with the ages and stages questionnaire. So I usually will just call it ask because we're asking. Our patient doesn't have suicidal intent. We have diagnosed her with depression and we're considering starting medication. And so depending on how well you know your patient and family and how much data you have gotten and what you've been able to get from discussions with your care manager or with her therapist, you might consider starting an SSRI. You would want to discuss benefits and side effects. You might want to think about following up via telehealth in 1 week. Generally with SSRIs, I will follow up in 1 week to look for side effects. That's my big thing. And at the same time, I won't start medication unless I've already had somebody actively in therapy because I want somebody else touch pointing this patient. You want to follow up in 2 to 4 weeks to be able to assess good effects. And with most SSRIs, the literature will tell you that you will likely not see a good effect until 3 to 4 weeks out. Sometimes you'll see it earlier than that. And then to recommend at least weekly visits with the therapist where they've already got an established relationship. So next slide. This is going to be talking a little bit about medical decision making and how you get the margin to meet your mission here. Next slide. So when you look at the new codes for the new 99204, 99214 for medical decision making, and you're looking at moderate problems, what you'll see in here is that these visits at least are 99214s or 204s and are moderate problems. So you have one chronic with exacerbation or progression. You have somebody who's depressed, they're seeing a therapist, they're not getting better. You already meet that there. Or one diagnosed new with uncertain prognosis. That again is germane to anxiety or depression in practice. When you look at moderate data, you have to meet at least one of 3 categories. So category 1 is ordering any unique tests, review of prior external record, review of unique tests. What about labs with some of these kids? I will very often do a CBC, a TSH, maybe a comprehensive metabolic panel, especially in a kid like this one who's gained a lot of weight in the last several months. So that would meet category 1. Category 2 is independent interpretation of tests performed by another provider. And then category 3 is discussion of management with an appropriate source. So if you have reached out to and discussed or gotten information through your care manager from a therapist, you would meet category 3. And then moderate risk, when we talk about medication and indications for medication, and particularly if you start it, you meet that moderate risk clearly. Diagnosis or treatment significantly limited by social determinants of health. I include insurance with this. So if you've got somebody who's got insurance and the only psychiatrists around you accept cash, that's a social determinant of health problem. If you work in a federally qualified health center and you don't have access, or kids with Medicaid and you don't have access to psychiatry, or the wait list is 9 months long, that's a social determinant of health factor. So these all play into that moderate MDM decision making. Let's go to the next slide. I would tell you, by and large, most of my visits with kids who have anxiety or depression meet the criteria for high or a 99215. So your high problems, again, that one or more chronic with severe exacerbation, progression, or side effects of treatment. You're going to be talking about this, whether it's that initial visit where that child is seeing the therapist and isn't doing better, or that child is not doing well. If you think about it, the data in the literature is showing us that in the last year, anywhere between 9 and 10% of adolescents have had a suicide attempt, which is horrifying. But that is a really important place to put this as a high problem. When you look at your high data, again, ordering your unique tests, interpretation of those tests. And then category 3 is important because that's the discussion of management with an appropriate source. So you want to look at who your historians are. It is often going to be the adolescent, but it's often going to be the parents as well too. And then thinking about an independent interpretation and discussion with an external provider on care management, which could be the therapist. And then your high risk, again, is going to be looking at your intensive drug therapy and talking about medications, good effects, side effects, what's happening with your particular patient. So next slide. So if you think about the amount or the complexity of the data to be reviewed, when you look at your 99214 in moderate, it meets one of these three categories. But in your 99215 is going to meet two out of these three categories. So if you're reviewing screens, you're reviewing messages from a therapist, you're talking with your care manager about what's going on with this particular patient. If you are discussing management, if you're talking about medication, you will very likely make these visits a 99215. They will meet that high medical decision making. So our 14-year-old, the patient and parent are historians. Mom's a historian. You've reviewed your screens. You've reviewed your notes from your therapist. You've discussed and started medication with risk benefit and a follow-up plan discussed. That meets the extensive 99215. So you can code for these because of the medical decision-making complexity. The nice thing about the 2021 codes, again, too, is that that medical decision complexity comes without having to do a physical exam. So that's what helps to make this by telehealth something that you can do and make your margin to meet your mission. Next slide. Using time. Time can also be used to select a code level in the office for outpatient services, whether or not counseling or coordination of care is part of that service. And one of the nice things about the 2021 coding is that you can include both face-to-face and non-face-to-face time. So that time you spent making sure that that list of intensive outpatient programs or partial hospitalization programs is there with the parent. The time that you take reviewing the screens or the therapist notes or talking with your care manager, if it happens on the same day as the visit, you can count that in with the visit. So some of the activities that you could do with time: preparing to see the patient, that whole pre-visit planning, counseling and educating the family caregiver, ordering medications or tests or procedures and reviewing them, documenting your clinical information, and then the care coordination. So let's go on to the next slide. So if you look at the new listed times, if you are going to be coding by time, the 2021 total time is going to be what you see in that right-hand column. So your 99204 is going to be 45 to 59 minutes. But again, that includes what you're doing outside that face-to-face visit. 99215 is 60 to 74 minutes. And those of us who work with these kids know that we spend this time with them and doing a lot of the care coordination and connecting and counseling besides that. If you look at 99214 and 99215, anywhere between 30 to 39 minutes or 40 to 54 minutes is important and is something that you can actually use that time with all the activities that you do around care coordination to be able to code those higher visits. Next slide. Okay, and I'm going to let Barbara take over.
Yeah. So I spoke earlier about the collaborative care, and these are the collaborative care codes. And like I said, we are literally enrolling our first patient in collaborative care this month. We've had our care manager in our office. It was kind of our own idea, if you will. And we hired her a couple of years ago, and we kind of makeshift, I guess, built our own model, and it's provided excellent care for our patients. It's provided incredible physician professional satisfaction as well as patient satisfaction, but it wasn't truly a recognizable structure, if you will, to be able to bill for her services in such a way that the collaborative care model offers. So collaborative care is kind of a triangular model where the behavioral health care manager is at one point of the triangle, the primary care provider is at another, and then a psychiatrist is at that third point. with the patient in the middle, and the various people on the periphery communicating with the patient, primarily being the care manager and the primary care physician. The psychiatrist is more kind of available in a population health type of way, such that you review the registry of patients that are enrolled in collaborative care on a weekly basis. So we are starting with this model. We have a psychiatrist that we will have access to once a week, and we will, in the patients that are enrolled in collaborative care, will be reviewed with the psychiatrist on a weekly basis. This is a proven model that gets the patients to a point of remission sooner than can be done in the makeshift ways that we feel we're doing right now, I think, on the most part, with the large majority of mental health that we've been seeing. So these collaborative care models require a lot of time when you look and see, and it is just that one individual, whoever that person is, that's going to be kind of that clinical staff person or behavioral health care manager, their thresholds they have to meet. So they do have a little bit of administrative responsibility to keep track of the amount of time, but you look at 70 minutes in a calendar month with it for that first month, and you think, oh gosh, it's an incredible amount of time. But in a month, first of all, this patient will be reviewed with a psychiatrist on a weekly basis. So there's 4 weeks in a month where, there's some time there. That patient is going to be discussed between the care manager and the PCP multiple times. Every single time you touch the psychiatrist, you're going to bring the PCP up to speed. And then, of course, the care manager or the primary care physician will be touching base with the family to say, this is what the psychiatrist recommends. So our care manager has, with the first patient that we've enrolled, had no problem whatsoever meeting the 70 minutes in the calendar month. So these here are the codes that are used for collaborative care. And next slide is the payment. Now, I don't want to be accused of any type of collusion. We haven't even started getting paid for this, so I can't even share, but these are publicly available Medicare CPT payment summary on these codes and what they're paying in the primary care setting. So you can see that code, the very first code of when you initially enroll a patient and spend 70 minutes with them, it pays $157 in the Medicare setting. So I would recommend that you look into whether you're part of a PO or an ACO or whatever acronym you're a part of, and if you're not, find one, because they can help negotiate for you and reach out to some of your payers and ensure that you will get paid for this. And it is paying. I have a link later that we can share with you of the various states that are paying, the Blue Cross anyway, I believe, in these various states that are paying for this collaborative care model. So next slide. So the follow-up is, Colleen, you were going to do this?
Sure, I'll do this.
Okay.
We were talking about this. This happens maybe 10 to 20% of the time. So 4 weeks later, your patient is doing a lot better. And in this case, she wants to get up and take walks. She's eating healthier. She's lost a little bit of weight. She's getting together with friends. She's seeking help in school and grades are better, and she's going to bed earlier. And this does happen. And this is actually really rewarding. It doesn't happen the majority of the time, but it does happen. And it's something that helps to move you on to wanting to do and see more and take care of more of these kids. So what you'll want to do is your follow-up time frame discussed. Generally, early on with medications, I like to follow kids at least monthly to see how they're doing. And in some cases, even more than that, every couple of weeks, even if they're doing well, because things can continue to change with kids. So, you can discuss what that follow-up looks like with that family. And again, what is the plan for what that child needs to do, what the parent needs to do, what we're going to be following up together on, and then getting, again, the screens and that data together. Next slide. So Barbara, you're going to talk
Okay,
about
yeah.
the mental health symptom template.
Yeah,
and
this is a
some
little
questions
this is
about
a little
EMR.
small.
Yeah.
Sorry, but hopefully maybe you can read it. Maybe you'll recognize our EMR. But what I did is I tried to consolidate on one page what is in our templates. So in this case, obviously, the review of systems, I intentionally marked everything as positive. So it does not coincide with the case that Colleen just presented. It makes this child look like they're doing very poorly. But I wanted you to see what questions we have templated for our clinical staff to ask. So they ask some constitutional questions about weight gain and loss and stress levels, cardiovascular questions about palpitations, chest pains, etc. So those are all the questions that get asked. In this case, I marked them all as reports so you could see them because they wouldn't show up if we didn't mark them as that the patient reported them. But what I really wanted you to see is that we routinely, no matter what the patient, what their end point is when they see the physician, their beginning point when they see the clinical staff, they will get a PHQ and a GAD-7 ordered as part of their standard workup. And the surveys, you can see that those got ordered. And then in order to get them documented in our EMR, we have them as a diagnostic test that then can be inputted, the value, the score that the patient got, and that allows us to follow the results sequentially. So that is what routinely, and then of course we're in the day and age of COVID where we have a third survey on there, a COVID screen. Next slide. So that was what got added routinely. In this case, this is the physician when they initially see the patient. This is the templated assessment and plan, as well as a normal physical exam that gets overlaid on top of what I previously showed there. And so the patient, when you initially see them, what type of, and again, the orders are probably the most important component here, that we are ordering that they schedule a recheck appointment in 2 to 3 weeks. And the other order, and this is probably the most important order, and it's not really an order, it's just a tickler, and that is had a new anxiety/depression appointment med start. And that task gets sent to our behavioral health care coordinator. So she gets alerted every time a patient gets seen so that the patient doesn't fall through the cracks. I might remember to send our coordinator a message. I might remember to curbside her in the hallway, but I might forget. This ensures that the patient doesn't get lost to follow up. She then can investigate on her own accord. She can check in with me and say, hey, what did you end up doing for that kid? You didn't finish documenting it. Where are we? Do you want me to follow up? I'll make sure they get in. I'll call them for their, to see if they're experiencing any side effects in a week. We'll make sure they get back in the office in 2 to 3. Next slide. And then this is the template where we actually did a follow-up appointment. And this coincides with where we are right now in the case that we're presenting. And this patient's doing well. So really the most important thing on here is, again, that tickler to just send something to my care manager that says the patient had an appointment today. It's just her way of knowing and not have this patient fall through any cracks. Make sure, because maybe I made a med change and I did something, or I told the patient I wanted them to follow up, and but I didn't. We know that happens. The physician doesn't document all the specifics of what happened in the encounter. But if the care manager is always brought into the loop, we feel that our patients just don't fall through the cracks. And I think I'll show you in a minute what I believe is a suggestion of some data that is supporting that. Next slide. So the follow-up, Colleen, or you or me?
Sure, we can do so.
I'll do this one. Okay.
Follow-up in 4 weeks where our patient is not doing better.
Yeah. So this is where she's not doing so well. She is struggling. She, the meds don't seem to be helping. We give her, so our care manager steps in. Again, she was brought into the loop. This patient hopefully didn't fall through the cracks. And now she has the opportunity to send out another PHQ-9, a GAD-7. I apologize for the baby screaming in the background. I'm obviously in my office. but she sends out some additional screens. She touches base with the primary care physician. And then we, make an appointment and bring this kiddo into the office. Do we make a med change? What's going to happen during that visit? Do we change the medications? And then this is where, if we're struggling, if maybe we've tried a medication or two, and it's just the patient's not doing any better, that a conversation with the physician about enrolling them in possibly collaborative care, where we can then, your therapist hasn't been quite enough. We would like to have a psychiatrist. They're just so hard to get into, but let's enroll you in collaborative care, and at least we can give kind of this population health model to your care, and come back with some psychiatric input on a weekly basis. Next slide. So this is the template for the child who's not doing well that would overlie on top of the original review of system questions. And again, the most important component is that we brought the care manager into the loop by saying there was a med change. This kid wasn't doing so well. And then she can decide. She knows what our limits are. It doesn't mean that she can follow up with them by phone in 2 months. When she sees something like this, she's making a phone call to them. She's touched base with the primary care provider, and again, making sure that we all are on board with the same plan for this child. Next slide. So like I said, we have some data, and we hired our care manager in November of 17. Actually, after attending the AAP PCE, where there was a huge focus on mental health, and some of my partners and I who were in attendance said, we got to do something. We have to do more. We have to do for our mental health patients what we're doing for our special needs patients, our asthma patients. And so we kind of came up with the idea of having a care manager specifically for mental health. And we just got fortunate to find and know someone who had that passion. So you can see our data from 2018, when we were kind of getting our the process in place with her, trying to track these better, get our templates set up. And so we didn't have as many patients maybe with the positive scores, but you can see in 2019 and 2020 it was about the same. And you're like, well, in 2020 we had COVID, and you'll see with the data here that sure enough, COVID has impacted the mental health scores. It's not super apparent right here, but what is apparent here is that the number of patients to remission who aren't having as high of positive scores anymore has gone down from 2019, where it was close to 100, to 2020, when it was a little over 50. And that, I would say, is a result of our care manager not letting these kids fall through the cracks, keeping a closer eye on them, making sure they're having more touches with us. And that's really what collaborative care is all about, the frequent touches, and then they can get to remission sooner. Next slide. And you can see here where I kind of compared apples to apples of the past 4 years, just on data from January through April in our office. We already have had 150 patients with depression, anxiety diagnoses, which is, last year it was around 80 to 90 at this point. And so that's really working out to be close to 1.2 diagnoses per day in our office, which is really incredible and sad. And so we need to continue to do what we can for these kids. Next slide.
All right, thanks, Barb and Colleen. We'll continue to ask for questions in the chat or the Q&A. And at this time, we'll turn it over to Dr. Barbara Howard from Chattis.
Hi there. First of all, I want to thank Colleen and Barbara for a fantastic and practical combined presentation. That was really, I have never heard anything quite like that. So I'm glad this is being recorded, because I'm sure a lot of people will be very interested. There have been some chats coming in that I'll try to answer a little bit as we go along. If I could have the next slide, please. So you know that I'm the president of Chattis, so I have a conflict of interest, and some of you are Chattis users and some of you aren't. But we've been working hard to try to improve care for teens recently with 2 different projects, one related to teen substance use reduction or elimination or prevention, and one having to do with depression. And both of these are intended to be projects that can be implemented primarily in primary care, which is really important, as I'll talk about in a minute, because you can wish to have all the wonderful resources that Barbara Periard talked about, but you may not have access to all of those for your teens, or they may not go. So a lot of this can be done in primary care, and we really need to be thinking about how primary care providers are transitioning to be a form of mental health providers. And I know Colleen has thought about that on the national level as well, especially as we reduce things like flu and strep throat, really being able to take on these problems in a systematic and evidence-based way is important. The other part of how we're approaching this is to consider, next slide please, including assessment of teen strengths. So we've created a questionnaire about teen strengths and goals, and this would be routinely used before regular check-in visits. And it's important for a couple of reasons. One is it brings up a positive thing that's very concrete at the beginning of the visit, because you can see what they've answered about their strengths and goals. Chattis, when you use Chattis, it automatically assigns resources to help support those strengths and goals, which can improve resiliency in itself. But the other part of it is that if there is a problem like depression or substance use, you may need to do a motivational style interview, and being able to use their goals as the counterpoint, reasons for making a health change can be very valuable. Next slide, please. So, next slide, please. So for every checkup visit, we've now created 2 new comprehensive teen health questionnaires that cover all of the AAP and Bright Futures guidelines and write about 90% of your note. So that's important because documentation is a problem, and having complete documentation helps you both after the visit, but also to prioritize what you talk about during the visit. And one of the questionnaires that's being used in our project not only asks about teen health risks, but then presents the teen with a view of their own health risks, some brief information on why those risks are important, and also lets the teen choose some goals that they might work on their own. Next slide. But when it comes to depression, we have modified the PHQ-9 so that when it's positive, it begins some questions useful for a motivational interview, and also provides the teen with suggestions for activation activities. So we know that there's some things that teens can do for themselves to reduce their depressive symptoms simply by activating other kinds of engagement. Now that's been harder during COVID, but it's not impossible at any time. And then Chattis automatically saves those suggestions and gives them information and a chat bot about goals that will help them move forward on those activation activities. There's decision support from the GLAD PC, bitten down into little bite-sized pieces and linked to the results from the teen questionnaires. And we also have a refer button that helps with that process that both Colleen and Barbara talked about in terms of providing a pre-filled consent form to exchange information and for a mental health provider to actually reach out to the family. So one of the problems you may have realized about making referrals is you don't hear back because you don't have a consent form to hear back, but you also may not they may not ever make it to the referral because you're waiting for the family to actually call the office and get an appointment, whereas this is giving permission for the actual agency to do that. We also provide for the teen a chat bot that has evidence in young adults that we've adapted for teens that actually provides a form of cognitive behavioral therapy, whether the teen ends up with a therapist or not. Now, there's other kinds of systems out there now, apps and so forth, mood trackers, for example, that can help also, whether the teen can make it to services or not. I saw that somebody had a concern about that. So there's much that can be done, whether they can get to a therapist or not. And by the way, I do sometimes start medicine without having a person in formal therapy because it's one of the ways to get them activated enough to actually go get therapy, as well as often being as effective as some forms of therapy. So I'm just putting in a pitch for that. So next slide is about substance abuse. I just want to say that we're working on that as well, but that's not what this particular seminar is about. But let me mention that it's often comorbid with depression. Be more likely to get involved with substances, and then you have work to do motivating teens to address that. Next slide, please. So in our project, so I wanted to mention a couple of things first from the chatbot. Inside the Youth Health Questionnaire is a tool called the SCOFF, which is an eating disorders screener, and it's triggered if the teen indicates that they're trying to lose weight or losing weight. So that's one good way to get some further ideas about eating disorders. Another thing I would mention is in Chattis, when one questionnaire is positive, it can trigger or chain to another more in-depth questionnaire, and this can be done either before the first visit or before the second visit. So the issue about time in primary care is really important. People are willing to come back for that other appointment if you've actually identified the problem with the patient. And then you can get more elaborate information by assigning more in-depth questionnaires for them to do. So Chattis, of course, has over 1,000 questionnaires now, including over 200 for child mental health. And that includes diagnostic tools that can be very helpful to you to sort out whether this is something you can handle or not, and also to share with any therapists or mental health providers. I wanted to mention that we have this project going on and that people who are Chattis users using Chattis standalone are welcome to join. Next slide, please. And the physicians will get MOC4 credit for this, which can be used for CME credit, a Best Buy certificate, off money for the office to provide information about visits. You can always come to our free monthly case conferences the third Tuesday of the month. Just let me know if you're interested. And you can email me if you're interested in this project at bhoward@chattis.com. And I know we only have 3 minutes left, so I can answer a couple of the other things that came up. And that is Chattis also provides a PHQ-9 graphic display over time, and a registry is automated. For anyone who's screened, you could choose what you want to have in the registry, but you could have anyone who's screened positive on the GAD7 or on the PHQ-9 or DEF on the ASQ. You're going to know about that already for sure. And being able to screen for ACEs is also really important. So I don't think that this is any longer a sort of an elective thing to do. It's really an important thing to look for current traumas, and in some cases assess past traumas. So we have some questions within our regular youth health questionnaire about trauma or discrimination or other things that may actually trigger symptoms of depression. But I really like the PEARLS tools, which are now required for Medicaid in California, but are really good to use anytime. So I sort of raced through that, but I know that probably people want to ask Barbara and Colleen some more questions as well.
Yeah, thanks, Barbara. That's great. Yeah, we have several questions. I guess for any of you, really. I mean, I think one of the questions that seems to be raised is, how do we get folks to fill out the questionnaires before the visit? And are there any tips or tricks that folks have to for the teens or for others to fill it out well ahead of the visit or ahead of time?
I think Colleen started to answer that, and that is by having them come in a bit early. And I know people pride themselves on getting people into the room fast, but actually your visit is going to be more efficient if you have the right information before they go in. So don't be shy about asking people to come early. And what we've noticed with our over 5,000 doctors using Chattis is that people who are more insistent, like they have a culture in their office, that questionnaires are a part of the visit and that that's an expectation, have more success. And especially once people have been identified with a mental health problem, making sure people understand how important it is to have information about how they're doing. And when you share that information, show the teen and the parent the graphic of how they're doing, that emphasizes for them the value of actually having done the questionnaires. They're very interested in objective measures as well.
I would agree that it has to become part of your practice culture, and Mia Bella, that is becoming part of the practice culture for everything. So we are sending out developmental screens before our baby visits, and we're sending out our MChat and our ages and stages questionnaire, and it's all going through the portal. And families are now growing up with, okay, I've got to answer this and send it back before the visit. And we find that they're much more engaged coming into the visit. So very similarly to that, it becomes how we do our work with our practice population.
Barb, how would you engage your care manager? Do folks don't fill it out? Can you ask over the phone? That was another question for folks that have technology challenges or can't fill it out? Or do you ask those questions over the phone? Is that a viable option?
That's last resort. Yes, they get asked over the phone. But what we found, and I saw the question in the chat, and I think I answered it, but is that we do the reminders a few days before, a day, day before, day of, and if they still haven't done it, the nurse or MA for that position literally calls the patient, and they get done. They call them and say, hey, you have an appointment in a few hours with Dr. Periard. Could you please do the surveys that we sent to you on their portal? And they do them.
And Chattis actually reminds until the question is done too, if you set the reminders in place. By the way, I'd like to mention that you can actually Chattis will actually allow you to schedule to have a PHQ-9 reminder every 2 weeks or whatever interval you want to help you with that follow-up, to get the follow-up information. Even when you're not seeing them as often anymore, you can still have their input in that way.
Yeah, and I think that's another question I have for you all is I noticed that your patient had a 6-month history of challenges, right? The one that you mentioned, and most of these teen follow-up visits or annual visits are annual, right? So it's every year. Is there any work being done from your offices to screen kids ahead of time or to identify them somewhere along the way, especially? Barb, I was impressed with how many of your kids are positively screened on that annual visit. And I've also seen plenty of data in COVID, how few kids have actually had their annual visit. So is it just too overwhelming, or are you looking at ways to kind of get out to your whole patient population to see who's having issues?
We have surveys for all of our well visits, and we embed the PHQ-4, which is basically the 2 primary PHQ questions and the 2 primary anxiety questions. And if they score positive, this is where we do resort to paper, because we already have the patient in the room reviewing their survey that they might have just filled out before walking in the door. We give them the paper version, and the patient will fill out the higher level PHQ-9 and the GAD-7. We will then record it electronically in our EMR, but hopefully it's capturing a few of those kids. I mean, it's definitely not offering a screen in the sense that, my annual mammogram does, but it's getting there. It's progress.
That's a perfect place where the chaining would work for you. So the chaining could actually chain to a more elaborate questionnaire right there on the spot when they first do the initial PHQ-4.
Yeah, Colleen, do you have a comment?
This is where your communication with your community partners and the people in that toolbox is so important. So what winds up happening is that if you have a set of therapists that you work with and you're interactive with, they're going to reach out to you to say, I'm seeing XYZ, and I've recommended that they follow up with you. If you have relationships with your schools and school psychologists and school personnel, you'll find that you'll get referrals in through that network as well too. And that's where pediatricians shine, because you know your community and you know your local specialists and your local therapists. So, become that network where you can surround these kids, because they're not going to easily come to you, as you had in that one very first slide at the beginning of this presentation.
Yeah. And then are any of you using, I know Dr. Howard mentioned a chat bot within Chattis. I've seen, I guess of late with technology, kind of a couple of cognitive behavioral therapy chatbots. One's called Wobot, one's called Sandbello. I haven't used them personally, but they're kind of a free app download and interact with the patients, actually have some research behind them. Has anybody been utilizing those in your practice as part of once you identify these kiddos with issues?
I've kind of liked Wobot for the my kids who are just anxious, because it's just a good little positive cognitive behavioral therapy. And in addition to everything else they're doing, it just is something as part of self-management.
Yeah. Barb, have you had any?
I agree with it. Well, it's interesting. We did focus groups with 78 teens, and they had a mixture of answers. And that is, for some, using electronics is actually far more acceptable than people. And for others, they say, no way, I'm never going to use a bot. So I think that being able to individualize it and have choices is really important. So it's really good to have in your repertoire choices for what they can do. And you know how teens are, they want to do it their way, which is good. But their way could include a bot or a journal. We have lots of those suggestions. That's what we provide through the Chattis resources, but you can think of these things also for yourself and have your own collection.
All right, well, I know we've gone a few minutes over time. Just want to thank all our panelists, Dr. Periard, Dr. Kraft, Dr. Howard. Thanks so much for the insights. Certainly at Anytime Pediatrics, we're excited to partner with Chattis. We're working on the integration so that we can add this to the virtual health repertoire for practices, including filling out the questionnaires, getting them done ahead of time. And really, my goal is to see how we can continually move things upstream to identify these kids with challenges, how we can get healthcare up technology-wise to do that. And then, really appreciate the insights from Dr. Kraft, Dr. Periard on the practical tips of the infrastructure, the collaborative care, population health, billing, coding, all those things. So I think we're at the beginning of some challenges here on mental health in our kids. So hopefully this webinar has been helpful, and the tools and tips will be helpful as well as we all work together to try to get them the care that they need. So again, thank you all very much, and appreciate it. Have a great weekend.